I would challenge any other health condition to have as clear a roadmap to research as NIDCD has provided us. So we have about 10 minutes for questions to the panel. If you would come up and state your name and affiliation and the individual to whom you are directing the question.
I'm Juliette Sturkins, audiologist. I've been in private practice in Oshkosh, Wisconsin, and I'm also known as the Hearing Loop Advocate of America. I think that any solution that we're going to come up with, and I've said this many times before, is that with my patients, what I would have called low-tech technology, basic technology, with a client who either uses wireless technology in the home for TV, or a hearing loop or a seat loop, a church that is looped, a house of worship, and a loop in a community place where they meet for events or lectures will greatly satisfy the needs of clients and makes my patients very happy. So I have experience in doing this. And I think that, any new technology at the moment has to offer a telecoil in a device so that these clients can access the hearing loop systems in places where we know hearing aids fail. Hearing aids fail to deliver in public places, and my clients come in saying, I want to hear. So it's maybe more of a statement than a question, but certainly I think the telecoil is something that needs to be researched.
Comments from anyone on the panel? Thank you.
I would just say that even though the workshop sounded hearing aid centric, we tried as often as we could to include other technologies and to ensure that the questions are related to multiple technologies to give benefit and improve outcomes, not just hearing aids. So, Judy.
I think in Amy's talk there was a statement that there's an assumption that the most expensive technology is always the best technology, and I think that's been mentioned several times here, and I think that was an issue that we tried to deal with in some of the research recommendations to do comparative effectiveness research and really answer the question about what is the appropriate technology for a particular patient. And we've heard a lot about needs assessment, and that's clearly needed.
And just to follow up, I mean, I have clients who walk through the house with a neck loop and an FM system to hear television 5 hours a day, 6 hours a day. So for a lot of our clients, just a television solution will greatly enhance their quality of life. There's no doubt about it.
Thank you, Juliet. Over here.
Yes, David Bergeron with the Hearing Partnership. I just would like to express my gratitude and how happy I am that the NIDCD has prioritized funding for community health worker research in the hearing healthcare system. We talked a lot about this yesterday, but I just wanted to share one statistic that I think will help underscore, I think, the opportunity. Several years ago, and I can provide the reference, I forget which agency did it, a federal agency did a census of how many community health workers are working in the United States. And under very many scores of different job titles, about 120,000. 120,000, but not in hearing health. So I think there's a big opportunity here. It's hard to imagine that there could be so many people involved in this way throughout the healthcare system, and they're not delivering high value productivity. So I think it's a big opportunity, and I'm very grateful to NIDCD for recognizing it. Thanks.
I think we had an interesting presentation on that yesterday, so thank you.
Okay. I'm Mary Hartnett with the Commission of Deaf, Deafblind, and Hard of Hearing Minnesotans. We're a non-cabinet state agency that advocates for and with people that are deaf, deafblind, and hard of hearing in Minnesota. So we do public policy and are very interested and are very excited to be here. And I also want to reinforce, actually in Minnesota, we have deaf community health workers, and one of the leaders of that movement who provide Community Health Worker Services in American Sign Language is Anita Buell, who we were able to get a Robert Wood Johnson award for a community health leader. And so there's that innovative work going on, and it's really made a difference in healthcare delivery in our state. But I just wanted to follow up with using evidence-based research to influence public policy. And Mr. Hoffman, you were talking about the 2020 Health Initiative and sharing that data. And I happened to quickly go online to look in Minnesota, and we're not tracking that. We have priorities that are set in injury, violence, cancer, heart disease, arthritis, stroke, oral health, and obesity, and those are the priorities for 2020. And I'm just wondering, how does that filter down? I see that you have your national board in there, but how is it that Minnesota doesn't recognize age-related hearing loss as not being a public health priority? So just curious.
Fortunately, I can't answer that. It is made available widely in their regional forum where this has been discussed. It may be, I'm just speculating, that we just reached a little bit beyond what people were able to absorb, because there are 42 topic areas. And you saw the number that were labeled brand new. And each one is very complicated. But actually what we hope is 2030. Maybe we can do that. Okay. And we also made it a little more complicated in that we included other things besides hearing, which we thought were very important. And tinnitus, which hadn't been included before. But certainly one of the coups that we had was to be able to include things about vestibular dizziness issues, which I didn't talk about. The issue was really, would the gerontology group prefer to have that? It turns out, no, they're happy to let us do falls. So we're very comprehensive, and we can't imagine why it wouldn't be included, but obviously isn't.
Keep it on the agenda, will you?
Yeah.
Hi, Meg Wellhagen. I just want to echo the need for the community-based research, and partnerships. But one of the struggles that we run into, I think now, it's one thing to do comparability research on the equipment, where I think you can have some more of a controlled environment. When you move your research into a clinical setting now, what we run into is major barriers, not only between the time elements in the clinics and the difficulties they have, even if they want to sort of participating in some of the research when they're ending up in many of the changes that are going on in the healthcare field now, but also the barriers that we have when we really want to do efficacy-based kinds of things where you want to say it's not unreal. You want to do it in the real world and have it look real so you can say this will work in the normal setting, because what you end up with is running into barriers with HIPAA and barriers with the CHR requirements and so forth. And so if you can't get access or you can't do something that's really feasible, and you don't have the money sort of to have your own research staff in a setting, it really does create issues around making your research as effective as you'd, or to work as well as you can and to get the cooperation. So I don't know how support for some of those issues or how we can work around some of those issues so that we actually can do some of the comparability research and people will listen to the data.
Thank you.
That's a very good point, Meg, and I'll just begin the discussion with the use of practice-based research networks, which is becoming more and more of a direction things are going, and I think both of the people on my right and left can speak more about it. I know perhaps Amy could talk about CHEER, and then maybe Luke could talk about what's going on in the VA.
Correct. The practice-based networks, basically this, for those who sort of don't know that term, it's where you have a group of practitioners that come together. They agree to participate in research. They try to use some similar processes for IRB, et cetera, sort of to streamline the whole research process. And then you may have a pool of them that agree to participate, and then different studies, different practices would participate in different studies depending on the patient population and what's under and it's been under study. We have one that NIDCD funds called CHEER, Creating Health Excellence Through Research, which is at Duke Clinical Research Institute, and it is otolaryngology, private practice. We also have a research grant that we just funded under this Accessible Affordable that is being done in a primary care practice-based setting in Michigan. So some of them are out there. trying to piggyback on one that currently exists. They're expensive to support, and infrastructure support, that's really what you're talking about. Infrastructure support is it's important, but it's very expensive. And so it's one of the struggles that all of the research community has, and that the NIH has as a whole, is how to provide an infrastructure, making it easy for those who want to do research to do it efficiently and quickly so that it doesn't become a burden. Yeah. And then Lou may want to.
I think the VA is an agency which faces very much the issues that you're talking about in terms of how do we actually deliver care and how do we study that. And there is a research community called the Health Services Research Community that is very, there's a lot of funding devoted to that community in the VA, and probably many of the health services researchers that are known throughout the country have been funded in the VA. And so we have a very strong infrastructure and support network that looks at exactly what you're saying, and that is the context of service delivery. And I think that's a lot of the reason where we'll do these wonderful evaluations in the labs and in the clinics, and we'll see these amazing outcomes and really real improvements, and then you move it out into the general health services delivery area and you see failures, because it's really the context within which the service, and I think the discussion we've had the past 2 days with the confusion that there is right now in this country about where do you go to get services and what's your point of entry and where do you start and what's the flow is an area that really needs a lot of attention as we think about that. But I think the other important thing about health services research is that you are trained differently in that area. You learn to ask questions a different way. You do a lot more survey data. You do quality improvement research so that your statistics, even the kinds of statistics that you use, and the way that you inform a service delivery system is very, very different. Then it also tends to be more interdisciplinary. We talked about multidisciplinary and interdisciplinary, and I think we've talked the past couple of days about how we're trying to move, particularly for chronic conditions, we are trying to move to a patient-centered care or a medical home environment, which is, of course, it started in the UK. It may have started elsewhere, but that was a chronic disease model. Let's get the right providers, and it's not the physicians. It's the physician, the nurse, the social worker, the community service workers. It's this model of a team working in an interdisciplinary fashion, because the goal is the patient goal. It's not the audiology goal. It's not the ENT goal. It's not the primary care goal. And I think that's the culture shift or the paradigm shift that you're trying to do when you get services into a clinic.
Yeah. Can I just clarify
Thank you.
too with the?
We're going to have to conclude this session.
Oh, okay.
I'm sorry. Apologies to those of you who had questions. And a tremendous thanks. Please join me in thanking this terrific panel.